Assalamu alaikum. Today we'll discuss ARDS management guidelines. We will talk about the definition of ARDS, ventilatory and non-ventilatory management. As we all know, the definition of acute respiratory distress syndrome include four important major items. First is the timing, within 1 week of a known clinical insult or new worsening respiratory symptoms. Chest imaging, there's bilateral opacities or bilateral lung infiltrates, the origin of edema, respiratory failure not fully explained by cardiac failure, oxygenation, mild, the PO2 FiO2 ratio more than 200 but less than 300, with a positive end expiratory pressure or CPAP more than 5 centimeter or equal 5 centimeter water, moderate PO2 FiO2 ratio from 100 to 200, and severe PO2 FiO2 ratio less than 100. So, if the patients of there's no availability to do a frequent arterial blood gases for the patients, we can use SpO2 FiO2. Yes, we can use it with a negative predictive value of 94% to 96% from mild to severe cases. From this point, the ARDS new global definition was established. This new definition add the to radiological features not only the chest X-ray or CT by lung infiltrates, also we can use the lung ultrasound by a trained professional. Regarding hypoxemia, in a mild case, if we use a high flow nasal cannula more than 30 liters per minute, it is considered mild ARDS. If the SpO2 FiO2 ratio less than 315 with SpO2 less than 97%, it is considered hypoxemia. So, for example, if a polytrauma patient, 70 kilogram, 170 centimeter height, have a chest trauma and lung contusion, respiratory rate of 35 per minute, SpO2 89% with bilateral lung infiltrates, echocardiography is normal, EBG showed that the pH is 0.4, PaCO2 34 millimeter mercury, and PaO2 61 millimeter mercury with FiO2 0.6. The ER physicians start to use the non-invasive positive pressure ventilation with pressure support 10 and B 5 centimeter water. Does this patient have ARDS or not? And do you propose non-invasive ventilation for this patient or not? Firstly, as we said, we classify ARDS to the mild and moderate and severe. In mild cases, the patient is receiving non-invasive ventilation and he's clinically stable and tolerating non-invasive, consider continuing non-invasive ventilation. If not tolerating and the patient is deteriorated, we have to go for invasive ventilation. In moderate ARDS and severe ARDS, please do not delay intubation. Delay the intubation will progress the disease. This patient, we have a PF ratio of 101. So this is moderate to severe ARDS, so we have to start invasive mechanical ventilation. How we manage this patient? We manage this patient, as we said, by ventilatory and non-ventilatory or conservative management. Regarding the ventilation of those patients, we have to start with initiation of invasive mechanical ventilation in severe ARDS patient using tidal volume not less than the double dead space to avoid hypercarbia, which is the dead space is 2.2, so we couldn't give the patient less than 4.4 ml per kg tidal volume up to 6 ml per kg if there is no increase in the plateau pressure more than 30 centimeter water. We have to follow the lung protective strategy by using the tidal volume, plateau pressure less than 30 centimeter water, and avoid check hypercapnia every few hours by using either the RT blood gases or venous blood gases. So the use of high P and the level of the BF ratio is less than 200, or we go for moderate to severe ARDS, we should go for invasive mechanical ventilation. Also, we can use veno-venous ECMO if the patient is the BF ratio is than 80, so we have to go for venous ECMO. We'll discuss also the neuromuscular blocker, when to start, and proning. There is no rule for high frequency oscillation ventilation for this patient. We can use the extracorporeal CO2 removal, but it's not evidence based. We can also depend on the driving pressure to be not more than 18 centimeter water. We can keep the patient's negative balance for the 3 to 5 days before trial of weaning a procedure. So these are the most important points regarding management of ARDS patient. How to ventilate, as we said, we calculate the predicted body weight. How to calculate this body weight? We calculate this body weight by calculating at first the height of the patients minus 100 in male and minus 105 in female, so we can get the predicted body weight. We can get the height by using the ulnar length, as we said before. From with this equation, we can predict the height of the patient. By calculating the predicted body weight, we can calculate the tidal volume, which will give to the patient from 4 to 6 ml per kg. And if there is improvement of the lung compliance and there is no increase by increasing the tidal volume, yes, we can increase the tidal volume up to 8 ml per kg. So the started with assisted controlled volume ventilation. We start with volume ventilation to see what about the lung mechanics and what about the pressure inside the lung by using the inspiratory hold to assess the plateau pressure. We keep the SpO2 between 88 to 94% and the BaO2 of 55 to 80 millimeter mercury, BaCO2 less than 45, and plateau pressure less than 30 or from 25 to 80 centimeter auto. The target of 88%, we can consider it in young adult patients and COPD patients, non-cardiac patient, there is no cerebral insult, while if the patient is cardiac patient or have a previous cerebral insult geriatric patient, we should keep the SpO2 not less than 94%. So we all follow the ARDS network by using fixed tidal volume, avoid increasing the plateau pressure, and follow the BEEP FiO2 plateau. But these two patients, patient A and number one, patient number two, A and B patient. In both patients, we use the same parameter of mechanical ventilation, but we will not get the same improvement in the compliance or oxygenation or uh, improvement in the lung mechanics. Because this patient have a different lung pathology or pulmonary affection. So in the part A, there's a very good area of normally aerated lung, the very small area of not aerated lung. But in this patient, the patient B, we found there's over retention in a large part of the lung, and there is large area of non-aeration or atelectasis in this patient. Why? Because those patients are not the same. We use the ARDS network um, uh, using the same tidal volume, plateau pressure, and beep table, because one size does not fit all. Please keep this in mind, because the same pathology, both patients do not have the same pathology. So patients with ARDS have a different body mass. Okay, that lead to ARDS may differ from patient to the patient. Functional residual capacity may differ due to different syndrome severity and other factors. As this patient have an ARDS due to intra-abdominal sepsis. So the main condition and the main pathology is the intra-abdominal sepsis and increase in the compartmental syndrome in the abdominal cavity. So we have to manage the reason before go for managing the lung condition, or in the same step while managing the lung condition. So in studies have shown that compared to plateau pressure between 28-30 centimeter water, plateau pressure between 25 and 28 centimeter water is associated with a lower level of inflammatory release and highest hyper inflation. So avoid the use of mechanical ventilation with the same parameters in both in all patients, because this action or stress of the ventilator will lead to affection of the alveoli, and the associated domination, the deformation of the structure due to stress is called strain, which is defined as a change in the size or shape referred to the initial status from the mechanical ventilation. So ventilator-induced lung injury will lead to atelectatic trauma, repetitive alveolar collapse and opening and reopening, volume trauma over distension of normally aerated alveoli due to excessive volume delivery to the healthy alveoli, and pyotrauma, which is the release of inflammatory cytokines and which will lead to multi-system organ failure in patient with ARDS. So, in patient with ARDS, during the acute phase of ARDS, there is a high respiratory drive. So, deep sedation does not guarantee lower respiratory drive. So, we have to relax and start to giving those patients a neuromuscular blockade. So, patient self-induced lung injury will occur in those patients. Diaphragmatic damage and hypertrophy of the diaphragm will lead to impairment of oxygenation, especially after weaning of the patient from mechanical ventilation. So the message: be careful when respiratory drive is high, regional stress and restraint may be also high. Okay, so in patient with severe ARDS, a 48 hours administration of non-depolarizing neuromuscular blockades has been shown to improve oxygenation and decrease the 90 days mortality, as well as decreasing the duration of mechanical ventilation and bar trauma. So we give the calculate the predicted body weight. We start assisted controlled ventilation. How to adjust the beep? To adjust the beep by using the PO2 FiO2 table. While increasing the FiO2, we have to increase the beep. If we are increasing the FiO2, but we couldn't increase the beep due to increase in the plateau pressure, so this lung is non-recruitable, and we should go for another plan of management. The high the compliance, the high the low is the beep, and the low the plateau pressure, which is called the open lung or recruitment maneuver. And how do we go for recruitment? Recruitment will increase oxygenation for few hours. Okay, so we can, it does not affect mortality. The So we can go for a recruitment for just improvement in oxygenation, and while doing a recruitment we should give muscle relaxants and heavy sedation for our patients. So the to sit beep at 5 centimeter water of the start, increase beep to 8 centimeter after 10 minutes. If there is increase in the compliance and the oxygenation, go to next beep level. If there is no improvement, do not go for the next further increase in beep. Okay, so in these patients we have to check for the upper inflection and lower inflection points. Upper inflection, there is a hyperinflation of the regional over distension of the alveoli, while in the lower inflection point there is alveolar derecruitments and increase in the airway resistance. So if this curve is shifted to the upward, so we use low pressure and we give high tidal volume, or we use high tidal volume and catching low plateau pressure. But if this curve is shifted to the right, or to the down, to, so there is increase in the pressure with a limited increase in tidal volume, or we increase the tidal volume with high increase in pressure. This is the volume pressure loop, which is very important while managing an ARDS patient. So if we increase the PEEP, we should follow the static lung compliance. It will be, if it's 33, we can increase PEEP, lung compliance increase to 37, 10 centimeter PEEP, lung compliance become 42, and at 12 centimeter PEEP, the lung compliance becomes 38. So we should go back to the PEEP of 10, as is PEEP of 12. There's increase in the plateau pressure and decrease in the lung compliance. So while setting PEEP in ARDS, we should know the patient his lung is recruitable or not by using the PEEP. If we can use PEEP more than or equal 15, so this lung is recruitable. If you couldn't use PEEP less than 10 centimeter water, without increase in plateau pressure, without impairment in oxygenation, without increasing the driving pressure, so we can use higher PEEP. If we couldn't use higher PEEP, or there's increase in the plateau pressure, we should use esophageal catheter to measure the intrapleural pressure. So what we will do, PEEP, after doing recruitment, it's recommended to gradually decrease PEEP from around 5 to 10 minutes until there is a full NbAO2. So it's called decremental PEEP trial. A full BO2 over 10% indicates that there is derecruitment. If the PEEP is set to adjust 2 centimeters above the level at which derecruitment occurred, this strategy resulted in a 4-hour improvement of oxygenation. So what is the PEEP endpoint? The best PaO2, the best oxygen delivery, best driving pressure, plateau pressure from 228 to 30 centimeter water, best aeration, the best possible lung compliance, and hemodynamic stability. We should check plateau pressure. As we said before, that the plateau pressure is that the pressure in the alveolar after inspiratory hold or after airway occlusion during inspiration. First, we check plateau by if the plateau pressure by inspiratory hold, and if it's more than 30 centimeter water and tidal volume is 6 ml per kg, we could decrease the tidal volume to be 5 to 4 ml per kg. And if the opposite, the tidal volume is less than 6 ml per kg, and the plateau pressure is less than 2.5 centimeter water, we can increase the tidal volume till the compliance more than 2.5 centimeter water. Then we should check for the pH. If the pH from 7.15 to 7.3, so we can increase the respiratory rate. If the pH less than 7.15, the plateau pressure might exceed the respiratory rate is 35. Tidal volume can increase the tidal volume by 1 ml per kg until the pH more than 7.15. But while increasing the tidal volume or respiratory rate, we should keep eye upon the plateau pressure to not to exceed the 30 centimeter water. If it exceeds 30 centimeter water, we should go for using the esophageal catheter if available. To improve, two important question: is the plateau is a critical value, or is the tidal volume is a critical value? Both are important value by using the driving pressure. The driving pressure and not the tidal volume may be the critical variable for lung damage and thus for mortality. So we should keep driving pressure, the difference between plateau pressure and PEEP, between 15 and 18 centimeter water, which is a very important point regarding mortality of mechanically ventilated patient. So the clinical predictors of recruitability: achieving VO2 FiO2 more than 150 at a PEEP of 5 centimeter water, decrease in the alveolar dead space, increase in the respiratory compliance with when PEEP was increased from 5 to 515 centimeter water. So these patients, we started invasive mechanical ventilation, and PF ratio is decreasing to 80. So we should go for venovenous ECMO. And before this, we should discuss very important point regarding the early management of ARDS, which is proning and neuromuscular blocker. We should, when to start proning and when to start a neuromuscular blocker is a very important issue. How to do proning? To do proning when the BAF, when to do proning when the BAF ratio is than equal 150, or using PEEP more than 5 centimeter water, using FiO2 more 0.6, and the patient should be hemodynamically stable, not severely acidemic, does not have intracranial hypertension, adequately paralyzed is very important. We should increase the FiO2 for for about 15 to 20 minutes before repositioning of our patients. So, to start proning position, as we said, the indication of proning, we continue for proning not less than 12 to 16 hours sedation and paralysis. We If the patient meeting the criteria of supine position, we turn the patient in the supine position for not less than 4 hours. If the PF ratio become more than or equal 150, using PEEP less than or more or equal 10, and the FiO2 less than or equal 0.6, we can turn the patient to prone position. Or if there is any complication of proning, if there is hemodynamic instability, if there is facial edema or any complication of proning position, we should turn the patient to the supine position. So proning improves gas oxygenation and has long been used as an adjunctive or therapy for severe or refractory ARDS. So, in the benefit of prone position, it will improve oxygenation, it will increase ventilation, decrease psychological shunt, improve ventilation area where perfusion remains the same at the basal, which is the basal part of the lung, which is mostly more mostly more affected during an ARDS, prevent the ventilator-induced lung injury, and enhance mobilization of secretion. So early proning is very important in mild and moderate and severe cases. We do not delay proning, and they use proning in the right position and right indication for those patients. So, if the patient, we do proning and we give relaxant and the BF ratio remain 77, we should go for ECMO, as we said before. So, what is the role of steroid in those patients, and what other intervention can be done for this patient? Steroid therapy. It We have a very strong recommendation to start steroid therapy if the PF ratio less than 200. So if there is the risk of complication is low, we should give steroid in those patients. And if there is a risk of indication of complication is high, consider steroid as case by case. As some patient, we start steroid and we have experienced attack of hematemesis or any bleeding, hematemesis or melena or There's increase in random blood sugar. Patients go for become acidotic, or the incidence of diabetic ketoacidosis increase by using steroids. So we consider steroid on case by case basis in a very strong recommendation for steroid. While if it is not very strong recommended in patient with mild ARDS, so we do not give the steroid for those patients. What steroid to give? Either methylprednisolone or dexamethasone. Regarding methylprednisolone, we can use two doses. Either we can give um, 80 milligram bolus over 1 hour the first day. Then we continue for 80 milligram infusion for 24-hour extended infusion for 14 days. If the patients uh, extubated w- extubated during this period but still oxygen dependent, we should continue for till day 15 on this on steroid therapy. And we will decrease after day 14 the steroid therapy to 40 milligram infusion. We can give 40 milligram infusion for another 7 days. Then we de-escalate steroid over 28 days till reaching 10 milligram daily. We can continue for 2 or 3 days. While using dexamethasone is different. We start with 20 milligram once daily for the five first 5 days, and if the patient improved during this period, become off oxygen, and saturation SpO2 become more than 94%, we can stop steroid. Okay, we if not, we continue on steroid for 10 milligram for 24 hours, 10 milligram for 24 hours for another five days. If the patient did not improve after this 10 days, there is a mild improvement, we can shift from the dexamethasone to oral steroid. If the patient will discharge to the from the ICU to the ward, we can continue for oral prednisolone. Steroid therapy in COVID-19, as we all know, we started with 6 ml per kg. I'm sorry, 6 milligram dexamethasone in the first four for 10 days, which equal to 32 milligram prednisolone or 40 milligram methylprednisolone or 40 milligram prednisolone for 10 days, or which is earlier. If the patient become not hypoxic and not oxygen dependent, we can stop steroid. If the patient remain hypoxic but we decrease the oxygen requirements, we continue on oral prednisolone. Okay, so also very important during management of ARDS patient is keeping the negative nitrogen balance. At first, the patient is um, uh, presented in the OR if he's dehydrated, septic shock, or fever, diarrhea. So we keep positive balance in the first day of resuscitation. But after that, we should go for active de-resuscitation of the patient to maintain the neutral cumulative balance between the third and fifth day. So, regarding conservative management for ARDS patient, we have to decrease or stop the maintenance fluid, continuing medication and nutrition, keep on urine output from 0.5 to 1 ml per kg, assess fluid balance every 4 hours, diuretics in case of positive fluid balance. And please avoid to be the person who will knock out the lung. Thank you.